You start your shift and pick up a chart with a patient with recent diagnosis of AML, and you find that some initial labs already show a white count of 50,000. And you're worried about an infection or maybe some oncologic complication related to this.
And on your way to see that patient, you get a text message from your bank about another charge on your account. And you wonder, should I have a budget or something to figure out if I'm overspending? In this episode of Critical Decisions in Emergency Medicine, we'll talk about budgeting, specifically the importance of that and how to create one.
We'll also talk about oncologic emergencies in their evaluation and management.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices mostly in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the June 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
There are also a lot of other features, such as the Critical ECG, the Critical Procedure, and as our listeners know, one of my favorite, the LLSA Literature Review.
So for our first lesson, Nick of Time, Navigating Oncologic Emergencies. Thank you to Doctors Abigail Burovsky and Suraj Nyalakonda for writing this article. 2/3 of oncologic ED visits get admitted. So we really need to be prepared for these emergencies.
Yeah, definitely. There's already an increasing prevalence of cancer, and certainly oftentimes they present to the ED for various conditions, some of which can be quite life-threatening, whether as a direct result of the malignancy or maybe complication of their cancer treatment. And a lot of times this affects multiple organ systems. Now, the authors of this lesson has very nicely organized the variety of oncological emergencies we may see in the ED. And generally, you can think about them in 4 categories: structural, metabolic, hematologic, and infectious.
That's such a simple way to categorize things. Well, let's start with the structural emergencies. What do you mean by that? What are the diseases we should be aware of?
There are a few. Certainly, we may think of SVC syndrome or spinal cord compression or pericardial effusion, as well as venous thromboembolisms. All of these conditions can cause a patient to rapidly decompensate, so it does require really prompt identification and intervention. So about each of these conditions, as we know, SVC syndromes, these patients can present with progressive facial and neck swelling. They can present with dyspnea and upper extremity edema. And the hallmark signs are JVD, cyanosis, and plethora. And these are more exacerbated when the patient is in a supine position. CT is the gold standard for diagnosing the extent of the compression on the vascular structures, and the treatment is focused on symptomatic relief, which may end up being intubation for a patient if they have airway compromise, or maybe they have ultramental status from cerebral edema. The patient may also need more disease-specific treatments, whether it's steroids, radiation, or chemotherapy. And in also some cases when there's a significant vascular compromise, there might be need for thrombolysis or endovascular stenting. Now, in terms of spinal cord compression, generally we think about these when patients are coming in with new onset back pain, especially if it's progressive neurologic deficits in any sort of a cancer patient. We know that a common presentation may be urinary retention or fecal incontinence, and MRI is the preferred diagnostic modality. If you do suspect it, though, you want to initiate high-dose steroids early, even before you get the imaging, and that can be dexamethasone 10 milligrams. And also consult, of course, our neurosurgery and radiation oncology consultants because they may need emergent surgical decompression or radiation therapy. So pericardial effusions, especially when it's related to malignancies, can be quite insidious, but unfortunately escalate to a tamponade physiology with very little warning. This can be related to the underlying lung or breast cancer or simply as a side effect of chemo or radiation therapy. Of course, emergency physicians are experts at using POCUS, and that can be helpful to look at right atrial systolic collapse, right ventricular diastolic collapse, respiratory variation in mitral and tricuspid inflow velocities, or even, of course, a non-collapsible IVC. And it can help you, of course, if you need to do an emergent pericardiocentesis for the ultrasound guidance. Even if you were to do a pericardiocentesis, of course, this patient will need more definitive management to prevent recurrence. And then finally, the last in this structural emergencies section, which is venous thromboembolism, we know that there's a higher risk of this with the first 6 months of a cancer diagnosis, and D-dimer is not useful since it can be elevated at baseline with any sort of malignancy. The studies showed that factor Xa inhibitors are non-inferior to low molecular weight heparin, so that is a treatment option for these patients. And of course, if the patient is presenting though with a massive PE, they may need multidisciplinary consultation to decide on thrombolysis or embolectomy, etc.
Wow, a great summary of a lot of scary emergencies. Well, moving on to the second category, metabolic emergencies. What do these include?
There's also several to consider, whether it's tumor lysis syndrome, hypercalcemia of malignancy, SIADH, or adrenal insufficiency. Of course, each of these can be a lesson on its own, but to highlight the two that we may not talk about as often, which are tumor lysis syndrome and hypercalcemia of malignancy. So, tumor lysis syndrome, it is usually related to malignancies with high cell turnover. So that might be Burkitt lymphoma or aggressive leukemias like ALL. There's a great table in the article that talks about related malignancies and medications. The danger, of course, is hyperkalemia, hyperphosphatemia, and hyperuricemia, which can all worsen if the patient also has acute renal failure. And other end organ effects that we worry about are, of course, arrhythmias and seizures. Generally, to treat these patients, you want to provide IV fluid hydration aggressively and also consider respiricase or allopurinol to reduce uric acid production. One key thing is that you actually don't want to give calcium for hyperkalemia unless the patient has a widened QRS or seizures, because that can actually worsen precipitation of calcium phosphate. Now, hypercalcemia of malignancy, this is the most common metabolic emergency and generally associated with breast and lung cancer as well as multiple myeloma. And we know that the severity of symptoms correlate with a calcium level of greater than 14 being an emergency that needs treatment with IV hydration again. And you can also consider loop diuretics, bisphosphonates, and calcitonin. If the patient is refractory to medical management, they may need hemodialysis.
Such a great pearl about calcium. Did not really think about that before. So let's move on to third category, hematologic emergencies. What are we talking about here?
Yes, this is also a range, and that can include hyperleukocytosis, leukostasis, dysregulations of the coagulation system, as well as autoimmune effects of cellular therapies. And again, there's much, much more to read about in the lesson, but to highlight two of them, hyperleukocytosis, as well as one of the inflammatory responses called cytokine release syndrome. So hyperleukocytosis by the name is that when the patient has a really, really high white count, and that can be related to infections or inflammations. But because of all these white cells, they can actually cause also organ dysfunction, which is then a symptom of leukostasis. And the most common organ systems involved are pulmonary and CNS, microvasculature. And so they're presenting with maybe shortness of breath and ultimental status. Now, another pearl with this is that in patients presenting with respiratory symptoms from leukostasis, your pulse ox is going to be more accurate than an ABG because these leukemic blast cells can actually cause pseudo-hypoxemia on an ABG because they are consuming oxygen a lot in that simple blood sample. Whew, interesting. Another treatment pearl is that if the patient somehow is coming in with, let's say, severe anemia or even concerns about volume overload, you actually don't want to give red blood cell transfusions or diuretics if you can avoid it because they can worsen blood viscosity and the symptoms of leukostasis. The actual treatment is starting cytotoxic chemotherapy and hydroxyurea, or even in some cases, leukapheresis. So you're going to need, of course, help from your oncology consultants with all of this. Now, cytokine release syndrome, we've heard a little bit about this severe inflammatory response in other disease processes, but specific to patients with cancer are those who receive CAR T therapy. And they can present really, really sick with a distributive shock. If you do suspect it, these patients may need treatment with tocilizumab or even pulsed steroids. And so consult your oncologist as well.
Wow, such great pearls. I don't think I've ever heard of pseudohypoxemia before, but definitely something to remember. Well, last but not least, hopefully something that I'm not going to be overly surprised with the pearls you're going to share with me here. Neutropenic fevers. I think I know a little bit about that.
Absolutely. We do see a good number of these in our EDs, and we often think about bacterial infections, but don't forget we should consider viral and fungal pathogens as well. And sometimes patients, though, can present with non-infectious causes of fever, such as related to drugs or tumor-related fevers. But of course, we want to leave that more as diagnosis of exclusions. So generally, when these patients are presenting, we're going to be giving broad-spectrum antibiotics as soon as possible, including Pseudomonas coverage. Now, outpatient management is possible if the patient is low risk and looks really well. And there's actually a risk stratification tool that's mentioned in the lesson called the Multinational Association for Supportive Care and Cancer, or MASC Risk Index. That can help you identify who's low risk. But of course, I think you should coordinate with your oncologist.
Great pearls. Well, thank you, Wendy, for taking the time to go through this article. I've learned a lot about oncologic emergencies, which, as you pointed out, we're just seeing them more and more. As the authors categorize it, it's very helpful to think of these emergencies as structural, metabolic, hematologic, and infectious. With structural, we're thinking of SVC syndrome, spinal cord compression, pericardial effusion, and venous thromboembolism. And we need to remember that all of those can rapidly decompensate, which is why we need to identify them pretty promptly and intervene as soon as we can. As for metabolic emergencies, we need to think of tumor lysis syndrome, hypercalcemia of malignancy, syndrome of inappropriate antidiuretic hormone, and adrenal insufficiency. With tumor lysis syndrome, the big pearl here is to avoid giving calcium for hyper-K, unless the patient has imminent decompensation, such as widened QRS or seizures, because that calcium can worsen the precipitation of calcium phosphate. For hematologic emergencies, we think of hyperleukocytosis, leukostasis, dysregulation of the coagulation system, and the autoimmune effects of cellular therapies. The couple of pearls here are for the hyperleukocytosis that can cause pseudohypoxemia on the ABG. And then the other pearl is that RBC transfusions and diuretics are contraindicated if they can be safely avoided. And then last but not least, neutropenic fevers, which I want to say this is like the oldest emergency. I don't know if that's a thing, but I'm going to go with that. Definitely to remember that bacterial infections are not the only thing, because fungal pathogens can cause that as well, especially if we work in a center where we see a lot of this. Having a clear pathway and follow-up plan for patients who are low risk, who can be managed as outpatient, can be really helpful, both to decrease the load on the patients, but also on the system. And for our critical ECG this month, a woman with syncope. The EKG shows QT prolongation, which we know is associated with risk of malignant ventricular arrhythmias. The risk really comes from when this prolonged QT interval is coming from abnormal calcium and sodium channel activity. That is also additionally worsened when you have electrolyte disturbances, structural heart disease, and that can increase that risk of syncope. Something to remember is that medications that increase the heart rate, whether we're talking about diphenhydramine, antipsychotics, can actually decrease the arrhythmia risk by shortening the duration of ventricular repolarization and therefore decreasing the time available for early after depolarization. Conversely, medications that slow the heart rate can actually increase the arrhythmia risk, so we need to keep that in mind. Patients with malignant ventricular arrhythmia who are pulseless, obviously, please defibrillate them. And remember that magnesium stabilizes the membrane potential and suppresses those early after depolarizations. In patients with persistent arrhythmias, think about a different treatment, such as isoproterenol or pacing, to increase the heart rate and reduce that arrhythmia risk. Switching gears to pediatrics, our clinical pediatric this month is a case of a 2-year-old girl with suspected autism spectrum disorder who comes in with a red and swollen finger after she chewed off her fingernail. you realize that there is circumferential blanchable erythema and a necrotic distal pulp with dry eschar extending to the DIP joint.
Now, in terms of pediatric hand infections, nail biting, which is called onychophagia, is very common, and it can often damage the peronychium and the eponychium, causing, as we know, a paronychia. Antibiotic treatment should include coverage for gram-positives, and if there is exposure to oral flora, in this case, also gram-negatives and anaerobes. We also want to obtain some x-rays to look for osteomyelitis, especially if the infection has been present for more than a few days.
Personally, I look forward to typing onychophagia as a discharge diagnosis.
Yeah.
However, it's important to remember that up to 50% of children with autism spectrum disorder develop self-injurious behaviors. There are a lot of resources that are only accessible after the diagnosis, which makes getting intervention early for young patients quite challenging because a third to a half of patients do not get diagnosed until they are school-aged. Emergency physicians can facilitate getting these young children earlier access to interventions to reduce their self-injurious behaviors. And switching gears to a completely different topic, our LSA Literature review is an article from ABEM Key Advances panel entitled Outpatient Treatment for Pulmonary Embolism.
I think this is a great review, as oftentimes we may run into trying to figure out whether or not a pulmonary embolism patient can be treated inpatient versus outpatient. And as we can imagine, low-risk patients can be safely treated in an outpatient setting if they have reliable access to the medications, certainly ability to follow up, as well as home support. It is easier now also because we have these oral anticoagulants like rivaroxaban and apixaban, and studies have shown really similar outcomes with no deaths and low 30-day recurrence. Now, the question, of course, is so who are these low-risk patients? Generally, I think our clinical result is that these are clinically and hemodynamically stable patients without any signs of end organ damage. Now, we do, of course, have some risk stratification tools that we can use. And those who are intermediate and high risk could generally have characteristics of right heart strain with elevated troponin and elevated BNP. If they are much sicker, like with signs of shock, end organ damage, cardiac arrest, then, of course, they're high risk. The particular decision tools that we may have encountered are the modified HESDIA criteria or the simplified PE severity index or the SPESI score, both of which are included in this feature. And they include some objective information such as systolic blood pressure and pulse, as well as oxygen saturations, as well as whether or not they have other pre-existing history of cancer or heart failure or other comorbidities, as well as social considerations. So definitely use those to help you risk stratify your patients.
Great summary of a great article. Moving on to something a lot less dramatic than pulmonary embolisms, our critical procedure this month is subungual foreign body removal. And we're thinking usually tiny, tiny foreign bodies like splinters. They're really small and really annoying. They can cause pain, inflammation, and infection. And think about it. We're right there, so we're probably a lot more efficient than a specialist or outpatient referral. Obviously, just like any foreign body removal, there's always a risk that there's going to be a retained foreign body, trauma to surrounding tissues, and so on. Obviously, a simple thing to alleviate the pain of the procedure would be to use a digital block.
Now, the technique that's described in this procedure involves lifting the nail and trimming it to a V shape to expose this subungual foreign body in order to remove it. There are, of course, alternatives, which is not removing the nail and just use a needle to slide under the nail to kind of pull out the foreign body. But there is a risk of causing a subungual hematoma formation and laceration to the nail bed with this alternative method.
Switching gears to ortho, are critical cases in orthopedics and trauma.
This is a 48-year-old man who fell onto his right side in a motorcycle collision and presents with a very obvious deformity at the distal right clavicle with tenderness when you examine him across the entire clavicle as well as over his scapular region. He also has limited range of motion. You get some imaging, and both the X-ray and the CT shows a displaced mid-shaft clavicular fracture with a comminuted scapular fracture.
Clavicle fractures are common, with 40% in younger populations occurring in traffic accidents. The Almond classification system categorizes these into 3 groups. 1 is midshaft, 2 is distal, and 3 proximal. The evaluation should always include a lung exam given the proximity of the clavicle to the lung apex and the potential for pneumothorax. Upright or weight-bearing x-rays can unmask displacements, especially in a distal fracture. In a proximal fracture, or if you suspect the involvement of the sternoclavicular joint, a CT chest is useful to evaluate the integrity of the mediastinal structures. An urgent ortho consult should be obtained for proximal fractures, as posterior displacement can impinge vessels or cause airway obstruction. Even if these fractures are successfully reduced, operative stabilization is still often needed. We should have a low threshold to refer all clavicle fractures to outpatient ortho, as surgical fixation can offer a faster return to activity, even if there's no imminent danger to the vessels or airway.
Now, in this case that's described, the patient has a floating shoulder injury type, which is quite uncommon and involves both the clavicle shaft as well as the glenoid neck, and that disrupts the superior shoulder suspensory complex ligaments. These can be managed operatively or non-operatively, really depending on the amount of displacement and the integrity of those ligaments.
Definitely an interesting diagnosis, a floating shoulder. So moving on to our critical image this month. It's a 10-month-old developmental delayed boy coming in with vomiting, decreased oral intake, and pain of the left upper leg. And there are spots, which are described as quote-unquote insect bites. He's noted to be alert with a mild fever, 38.1 Celsius, and stable vital signs otherwise. On exam, he has clear nasal discharge and normal heart, lung, and abdominal findings. When you examine his left thigh, you note pink papules with swelling and induration. So you get a point-of-care ultrasound and x-rays to further evaluate the area.
The ultrasound actually reveals some cortical disruptions of the femur that indicates a fracture. No particular fluid collections to indicate an abscess, nor any cobblestoning to suggest cellulitis. And then the x-ray also confirms this femur fracture.
Of course, at this age, non-accidental trauma is our main concern. And a skeletal survey should be performed in all of these cases, especially in patients who are 24 months or younger. Unfortunately, this patient was found to have a healed midshaft ulnar fracture, which obviously increases the suspicion for non-accidental trauma. The patient was admitted for further workup and social services. So our second lesson of this issue is balancing the books, Budgeting 101 for Physicians. Thank you to Dr. Laurel Barr for writing this article.
Now, this is not a general topic that I would think of as emergency medicine, but a very important one for emergency physicians.
Oh, absolutely. This is an important part of our well-being so that we can actually function better at our job. Money does not buy happiness, but what we know is that increased income to a certain extent is correlated with happiness.
That makes sense. So then let's start with some basics. Do we really need a budget?
Oh, of course. Just because we have a high income does not mean that we're going to have a fulfilling life with all that money. Financial discipline is extremely necessary, and part of that is a budget. After a financial plan is created, a budget can help track where money is going so that spending habits can be aligned with financial goals. Whether we're talking about a house, a car, a wedding, avocado toasts, or anything else.
Those avocado toasts add up.
So let's start with a couple of things.
To make those avocado toasts happen, let's maybe start with some of these terms. What is compound interest? And what is the rule of 72?
So compound interest is interest that is calculated on both the initial principal and all previously accumulated interest. Now, it's a great thing when you're investing money, so you're getting more money on the money. And it's not so great when you're borrowing money, because now you're owing more money on the money. Compound interest increases exponentially, and that's an important concept to remember. Rule 72 is a related concept. It basically describes how long it will take an amount of money to double. It is defined by the formula T equals 72 divided by R, where T is the length of time in years for the money to double, and R is the interest rate, like as a percentage. And if this doesn't make sense, if you look at the article, it has multiple examples that make this make sense and simplify it.
I love it. Let's make it simple. But let's come down to a very critical decision. which is why is it hard to become the rich doctor?
Well, there's quite a few reasons. One is peer pressure to display wealth as a symbol of success, as well as student loans. And the thing with student loans, it's not just the amount that people owe, but it's the fact that having so much sort of desensitizes you to acquiring more debt. What's an extra $1,000 when you have $400,000 in debt? Not a big deal. And another important reason student loans matter is the concept of opportunity cost. Now, if you're spending X amount of money on interest, whether it's a student loan or an unnecessary purchase or whatever it is, you're not spending it on something fun, on an investment, or on repaying a loan that's more important. A quote from the article that I like is, "Too many people spend money they haven't earned to buy things they don't want to impress people they don't like." An alternative to that is the concept of value-based spending, in which a person evaluates each purchase based on the value they will get from it, rather than the actual dollar amount. And the value that one person assigns that purchase may be very different from the value another person assigns that same purchase. The running joke here is the avocado toasts, right? If that's something you value, then it may be worth whatever dollar amount that is for you. And for somebody who doesn't value it, then maybe they should not be spending their money on that.
Very good points. So let's really go back to the concept of budget. How do we start making one?
Well, first, we need to categorize our expenses: rent, food, entertainment, and then decide which categories to prioritize spending money on. Expenses need to be grouped so that they're easy to understand. They can either be grouped to fixed and variable, so fixed like rent and insurance, it's the same thing every month, and variable, things that change every month, like food and entertainment. Another way to categorize them is to think of mandatory, like food and shelter, and discretionary, like travel and entertainment.
Okay, that's all well and good, but what would be considered a reasonable budget to be successful financially?
Well, the article discusses several budgeting strategies and goes into a lot of details and examples, so definitely take a look. They discuss 3 strategies: zero-based, 50-30-20, and reverse budgeting. To simplify it, zero-based budgeting is basically a method where you allocate your entire income across specific spending categories so no money is left unassigned. So basically, you figure out what's your monthly income, you come up with the spending categories, the ones we talked about before, and you assign every dollar to a category until the balance is zero. That's where some people talk about the concept of envelopes. And if you kind of think about someone's aunt or somebody's grandma who has like envelopes, oh, this is the one for the gifts, this is the one for the food, this is the one for the rent. And now you have digital aspects of that. The 50-30-20 budgeting is a top-down approach where the needs are covered and then your less immediate expenses. So 50% of your spending is the needs, 30% is the wants, and 20% is savings and debt. A good thing about this concept is that the more money you make, the more money goes into your savings and debt repayment, not just you make more money and you end up spending more money. The concept of reverse budgeting is what people say, pay yourself first. So you prioritize saving and debt repayment by automatically allocating portions of the income before your paycheck is even accessed. So that just automatically gets withdrawn from your accounts. And then the remaining goes to fixed expenses, and then whatever you have left goes to the discretionary spending. And that way, it's easier for you to, 1, save, but 2, really know how much money you have as disposable income. Again, the article has phenomenal examples with graphs and numbers that make this really simple, so definitely check it out.
Okay, I can see that. Now, a lot of this comes down to the actual nitty-gritty, which is tracking and all of this. How do we track spending?
Well, good starting points are your paycheck, your tax forms, and your bank or credit card statements. Paychecks show you the income, show you your deductions. Your bank statements and the budgeting apps can help you categorize spending. It's important to review yearly expenses against income from tax forms to really understand the big picture of the overall spending, including infrequent costs like tuition and insurance.
That makes sense. Now, what if the math does not work, which is when spending exceeds your earnings?
Well, if someone is overspending, they should closely review their finances to identify which expenses are truly essential and which can be reduced or just completely eliminated. This may include cutting low-value discretionary spending, such as subscriptions, or that daily cup of coffee that means nothing to you but is adding up. Or you can reduce your fixed costs by delaying major purchases. Paying debt more aggressively and increasing your income, just as through extra work, can also help. Acting early makes these financial adjustments easier and helps avoid long-term debt and delays in achieving financial independence.
Now, the reality is sometimes we just don't have the cash for an important and a financially sound purchase, and the only answer may be a loan. And so what can we do to improve our chances of getting a good rate for these loans?
3 words: better credit score. The article goes into the details for that, and understanding how your credit score is calculated allows you to figure out how to make it better. Things like payment history, credit utilization, length of credit history, types of credit, and new credit are important factors. So things like paying your bills on time, not closing your oldest credit card account even if you don't use it, asking for a higher limit on existing credit card accounts, opening new lines of credit, all of these can make a huge difference on the long run. It's also important to check your credit history often and regularly to monitor for fraud.
So this is such a wonderful lesson on an equally important topic for all of us to review on how to optimize, of course, our financial success. Thank you, Danya, for taking us through it. So hopefully our listeners were all able to take away some tips regardless of their stage of career. But maybe for those who are early in the careers, I think some of the things that we try to reiterate are that you do want to have a budget so you know where you're spending money and how to allocate your income to each of these types of category of spending, whether they may be fixed and mandatory costs like our food and shelter or more discretionary spending such as on travel and entertainment. And you can also go about it with several different strategies, whether you allocate every single dollar to a type of spend or general categorization of what percentage for your needs, what percentage to your wants, and what percentage for savings and debt repayment. But the key again is you have to look at what's coming in and what's going out. The other thing to consider is that certainly as you build up your wealth, you may need a loan for large purchases, whether it's for cars and homes, etc. And to improve our chances in getting a good rate, that does mean we also have to be cognizant of our credit score and our credit history. And the article also provides some tips on how to improve that, considering things like your credit history as well as numbers of lines of credit. So definitely check out this article. For our drug box this month, it is on the drug acetazolamide, which we know is a carbonic anhydrase inhibitor and a diuretic that we often use to treat conditions like glaucoma, sometimes epilepsy, as well as altitude sickness. It does, of course, lower the hydrogen ions and the bicarbonate levels in our body, and it can also be used for short terms for acute angle closure glaucoma or longer term for open angle glaucoma. There are also some off-label uses, such as for periodic paralysis and altitude acclimatization. The doses are different for each indication, so definitely check out the drug box for those details.
And last but not least, our Tox Box this month is boric acid toxicity. Well, boric acid toxicity thankfully is rare and causes mild GI symptoms, but severe cases, which unfortunately would be infants or large ingestion, can affect the skin, kidneys, and central nervous system. Boric acid is found in insecticides, antifungals, and preservatives. Patients can present with vomiting and diarrhea. What's interesting, it can be blue-green diarrhea. Patients can have a very funky skin rash described as boiled lobster because it's red, orange, and peeling. The CNS effect, unfortunately, happens in our smaller patients, our infants, which is seizures and lethargy. Possibly patients can have other things like hyperthermia, shock, liver injury, and kidney damage, but those are a lot less common. The diagnosis is just general labs to evaluate for the liver injury, kidney injury, and ECG. Boric acid levels are not really routinely available. The treatment for these patients is supportive, and if it's less than 1 hour, then gastric lavage may be helpful. Activated charcoal is absolutely not effective, so don't even waste your time. And in patients with severe toxicity, dialysis may be an option. If patients have anything more than just mild GI symptoms, just go ahead and admit them.
Such a colorful toxicity.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, I hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decision publication, as well as our podcast, always informative, often enlightening, and never boring.
Follow us on social media. My handle on Instagram is @Dr. Danya Khoujah.
Mine is @Dr. Wendy Chang.
And until next month,
bye-bye.